Hello everyone, this is Sachin Gaur from Innovation Curious. I hope you are having a good day so far. We have a very interesting topic today in our knowledge series with our partners Kanbalt, Tatu Biotechnology Park. I just want to introduce this initiative. As some of you might know, Skanbalt and Tatu Biotechnology Park. We are launching this initiative to basically bring Europe and India together. Today in the webinar, we have a focus on Sweden. I would like to just say a few words about our own organization, which is Innovation Curious Foundation to Healthcare and Excellence. Basically, we have a one-line motto, which is to bring down the healthcare delivery cost and improve the quality of care. The primary idea was that a tool like webinar enables easily to share good ideas, and hopefully, we also get to see each other face to face based on these ideas that we share with each other. And today we have two very interesting speakers, Mr. Lars Lindskog and Mikael Wintel, who are going to present what they are doing in Sweden.
Thank you. It's Lars from Sweden.
Yeah, so what's the temperature in Sweden right now?
It's winter and 2-3 degrees below zero.
Okay. Also, just checking with Michael, I think you are traveling, Mikael?
No, I'm sitting in the office, but I can hear you loud and clear.
Okay, very nice. So I was also expecting that Janusz Pikani, as you know him, would also be able to join him.
Thank you very much. I would like to introduce Skanbalt. Skanbalt is a meta-cluster organization of health and biotech clusters around the Baltic Sea, which is already been around for the last 15 or so years. We embrace 11 countries, several thousand companies through our membership clusters. We have close to 85 universities in this region. Currently, directly, the number of clusters is involved is plus, and we are very happy that we have now, since 2 years, been cooperating with Innovation Curious. And this initiative, what we have launched now, is actually a way to bring our partners in Skanbalt global arena, and this is cooperational effort with Indian partners, and we hope that this would be good success for the time being. So I'm happy to answer questions later. So thank you very much.
Okay. Thank you, Janusz. And I was just sharing that why this cooperation is important and why this webinar series. So I think you would agree with me that this is a good, easy way to exchange thoughts, and maybe it will lead to further more collaboration between India and Europe.
Yes, absolutely. Absolutely. This is our aim, and this is also our effort to bring more expertise to India. And of course, we would like to learn also about the Indian expertise and also about the Indian market and the health and biotechnology fields.
So before I ask Lars to start with the presentation, I would just like to formally introduce Lars and Mikael both for the audience. So Lars is a portfolio manager of SweLife, which I understand is the Swedish research organization for healthcare, and he's a portfolio manager for Sweeper Project, a Swedish national initiative to support the usage of systematic health data in personalized medicine. Senior lecturer for Department of Applied Information Technology, Gothenburg University, and regional developer Healthcare Head Office, Region Västra Götaland. Dr. Lindskog has a long experience of digitalization of radiology, pathology, and teledermatology. His research is based on interoperability with a focus on semantic interoperability driven by the profession. Today, working together with the profession to create infrastructure components as medical machine readable lexicon and synoptic histopathology protocol that will increase the automatic portability of data from various IT systems to better support the journey of the disease that will include actors as the individual, clinicians, researcher, and industry. The need for data increases enormously as many factors, each with a marginal influence, build the basis for the personalization. So I think that sounds very interesting, Lars. You seem like to be the right guy for this new age of artificial intelligence. As they say, data is the new oil. So I hope that you will today tell us how to extract that oil and a little bit about Mikael. So Mikael Wintel has worked with Healthcare Västra Götaland region since 1989. During the first years as VGR, he also worked as an instructor for United Nations, where his first assignment was to train the mobile army hospital team that Sweden sent to Somalia in 1992. In the beginning of 2002, he also co-founded IHE and DICOM Consultant Company. In late 2001, Mikael became manager of the Department of X-ray Technology at Sahlgrenska University Hospital in Gothenburg, a position he held until 2006 when he became CTO for the university hospital. Mikael worked as a lot with creating a fundamental for regional collaboration within the area of health informatics and gave him the opportunity in 2008 to start work as the medical CTO for the region healthcare informatics at the Department of HSA, which is Healthcare Governance VGR. Mikael also teaches at Chalmers, which I believe is a very reputed university in Gothenburg and in Sweden. Mikael started to work with digital pathology in 2006, and in 2012, Mikael became the chair of DICOM Working Group 26, Digital Pathology. Also doing work for the IHE Palm Group, creating an integration profile for digital pathology workflow. Mikael is also chair of HL7 Sweden, now working with the creation of future healthcare informatics environment that will be the best platform of healthcare in VGR. So that sounds that like, you know, we have two very knowledgeable people today with us. So I feel very fortunate. And just to explain a bit of modalities to the audience, since we have the honor and privilege of having the two very knowledgeable people, so you can type your questions using the questions tab, and we will assign these questions to them once they are done with their presentations. And you can type your questions at any time, but they will be answering them later. And the sequence of the presentation is that Lars would be speaking first and followed by Mikael. So over to you, Lars. Very warm welcome from India, and we look forward for your presentation.
Thank you very much, and thank you for the kind talks about our background. I hope that you will see my screen now. I will try to enlarge it a little bit also.
Yes, we can see your screen. If I may request you to make it in full screen, like you can go into the presentation mode. Yes, that's better. Over to you, Lars.
Thank you. I will give the first part of this webinar, and Micah will follow me. Just for fun, I took this image to see the difference between the two countries. And as you see on the right, left side where we have Sweden, I have also the light green parts that is the rest of Europe. But when it comes to the density, we have 23 per square kilometers in Sweden, and you have 400 per square kilometers in India. So I think that's quite interesting to understand and see. So we see, we will change the image. As we spoke about, I'm working for a national initiative that is called SweLife, and what they are looking for is to improve the public health and also increase the innovation in healthcare, and to have continuous growth in the life science sector. And I must say, working previously with Scanbalt, that's also one of their goals, to take care of the innovation in healthcare and also to continue the sustainable growth in life science. And my message back today is that the best growth we can do is when we grow together. So I think this initiative to have this webinar with India is very powerful for us in Sweden. Let's see. I will give you just a short note about the laboratory medicine in Sweden with a focus on pathology. The number you see here is actually the number of doctors we have in each domain. So if you look at pathology, we have 417 pathologists. So it's around one pathologist for 40,000 inhabitants. And one pathologist is serving 154 other medical doctors. It's a lack of pathologists today, and we are also in the transformation now to become more and more digital. And hopefully we will see that we can work more effectively with data that is coming out from pathology. When we look back to what has happened, you can see we started to look inside the human body already in the 1500th century, and we have been growing with more and more knowledge and understanding how we should work with cells and pathology slides to decide on the diseases. Today we see that the digitalization is becoming more and more critical for us to use all our data to, as you talked about, using artificial intelligence to become even smarter than before, and other new ways of looking at our data that can be of a beneficial things for healthcare. In Sweden, we have 31 pathology departments. As you can see, they are concentrated morely in the big regions, Stockholm, in Gothenburg and Malmö. That is the three big cities in Sweden. In the northern part, you can see it's not so easy to get access to pathology services. We try to keep up a very good level of quality, and I guess that's also some of the work you are doing all over the world, and also very good in India. And we try to harmonize the way we are looking at pathology images so we see the same results all the times. This is a very important work for us in Sweden to continue to have a good quality in pathology. So let's go back to what I'm working on a daily basis for SweLife in something we call a sweeper project. That is the initiative to support the uses of systematic health data in personalized medicine. Sweeper is actually an acronym of Swedish personalized medicine. You all see the changes now that we are moving to be looking more on the individual than on the group, so to speak. The three overarching aims we have in Sweeper is obviously to use the expertise and resources nationally as well as internationally in a sharing and caring environment. I've been spoken before with you guys, but I can see how we can cooperate better with telepathology and other teleservices in the future. I know Janos has been very involved in that type of work previously with Scanbalt. The growth and the collaboration and competitiveness. I think they are working together, the collaboration and competitiveness, because if you collaborate with anyone, you don't know what is happening. So it's also important that we share our experience with each other. And obviously to have a gender equal and personalized health and medicine more and more in the future. This is something we are working more and more in Sweden with, where we look at illness, risks, and healthy. Sometimes we forget that most of the time, most of us are actually healthy. And the critical thing is perhaps to see when the risk is rising and how to become a shorter time in the illness. So therefore we talk about precision medicine, but we are also starting to talk about precision health, and obviously then the wellness. And as you said, the oil of this is the individual's data, obviously. So in a way, and we will share more paperwork, is obviously how to look at legal guidelines. So what we are doing has a trust with the citizens and is also legally accepted. We are looking at procurement guidelines, so we can have many interesting vendors to be a part of this. And also on the lower level, we are looking at machine-readable medical lexicons for the computer systems. I will talk a little bit more about that later on. And we hope that the results and lessons that we have from this SWEPA project will be used in the SWELIFE project that create, manage, or in some way depend on health data. So we are closely working with the pharmaceutical industry also in this project. So when we looked at this, we understood that one of the most important things for the future is to have a common language. And if we think about that, the common language in the future will probably be used mostly by computers. And so we needed to find a way that we were using all these codes that we have to try to translate our findings into more structured information and how they can be used together with machine readable code. So we're actually working now in pathology to see how we can use synoptic histopathology structures to do this. And I don't know how well you are with these levels of e-health with structured reports with SNOMED CT. But the fundamental steps is obviously the development of standardized synoptic pathology protocols, and we are working closely with the US and UK and Holland today. And I would like to know more about what you're doing in that area in India in the future. And obviously together with Janos also to understand if we can do more things in Europe to have the same way of looking at synoptics pathology protocols. When we look at the protocols, we will obviously link them to SNOMED CT, that is the description codes that we are using more and more to understand and to archive what we have been doing, and also how we could better do an electronic implementation of those protocols into the environment and into the systems that we are using in healthcare. So in Sweden, we are now trying to work this to be more as a routine at the pathology laboratories. We are discussing with the company that is providing the laboratory information systems, how we could handle this together with them. We are looking more how we connect these metadata to other registers. We have the quality registers in Sweden, but also the biobanks for Sweden. And the critical thing is not to do it once, but to continue doing it all the time. So we have big and good discussions how to continue to have the management and maintenance over time for this type of medical records or synoptics lexicons. This is just texture about what I said previously, so you can see this and read it later. What we have done, this is some part of it in Swedish, but we have actually, just to have a proof of concept, put it on the web also. So you can see this is where the pathologists can, by just using drop downs, decide what preparate he has been using, the stent, where it comes from, the area, and so on. And here on the right side, you can see how it's translated to SNOMED CT codes. And by the end of the report, they can just do a summary text that is generated and sent it or printed or exported to anything in a good format. And Micah will talk a little bit more about FHIR standards perhaps and DICOM that can use this type of information. So I think it's a very interesting project from the point of view that it actually supports the pathologist to do a better work because he can use it very structural. It is creating the metadata that will be the oil for other to use when we are doing research or if we want to do some other applications to support decisions. And the third thing into this the uses of the medical lexicon is obviously the summary report that we can give the clinicians standardized way of receiving the information from pathology. The purpose is obviously, as I stated, to use the information systems to put the information into cancer registers, to other quality registers, and to the biobanks also. This is interesting work. We do it together with the Swedish Society of Pathology. We're doing it with PALGA, that is the organizations in Holland that has done a lot of those protocols already. My team, the SWE-LIFE Sweeper team, but we also do it with the Swedish National Board of Health and Welfare. So we have a very good contact with the Swedish welfare, and also with the Department of Pathology and Microbiology in the University of Nebraska Medical Center. And we are looking forward to understand and see if we can do something together with you in India also in a more formal way. So with that, I end my time of my presentation and I will leave to Michael. And you, Michael, just say next slide and I will change for you. Thank you.
Yeah, sure thing. I will talk out of this agenda and address some of the issues that Lars mentioned. He mentioned it out of a national perspective, and I want to take it down to our regional perspective when we enter the pathology domain and needed to look into how do we need to change the way we work to provide better care, more precise care, personalized care, but also in consideration that we have a lack of pathologists, can we use the technology to ease up that burden that it's hard to recruit productive pathologists in Sweden and also in Scandinavia. So I will do a little bit of background from a business perspective, then late disease, challenges, standard, summary, and conclusion. Next. So we have in Sweden at least been working very hard on a volume-driven healthcare. Every statistic that and then follow-up is done by the quantity of things. Now in the recent years we have tweaked that into the value-driven healthcare, and by doing that, that also involves the patient themselves, because they are a very good source of information, and also they are pretty interesting on being part in their own healthcare and in some way define the process that we are providing in a more personalized way. Next. And this is hopefully known by everybody. If you go from late disease to early health, and that's also what Lars showed in his one of the first images, where we see before we get ill, we have the risk management, and this is how to go there. And this is just an example where we have from breast cancer, where we have increased the 5-year survival stage of when increased diagnosis. Next. And in this, we also see that early diagnosis saves costs, and due to breast cancer, we see it's a huge savings. And this is just the money. When you interview the patient, we see that we have more soft values that are not that easy measurable, but we see them during the interview we have with the patient. And by doing this, this actually put a lot of pressure in towards our healthcare system due to lack of some of the specialities in medicine that we strive with. And that's why we're looking to, can we use the new technology to decrease that gap? Next. And what we have defined as our key challenges for healthcare, it's a lot of them, but what we have been focusing is actually on the information, the accurate information. Just because that you have a system and share information, you need to provide trust that our staff could actually know that this is the only information and it's correct. And what we have seen as a legacy, we have that we have been hostage by vendors that have provided the lock-in mechanism, and we from our side have been very poor when we had the demands that the information is actually one of our resources. And when we leave a system, we need to transform or migrate that information to provide a good health for our citizen. So that is a huge area where we are working very tough towards our vendors right now, that the information is one of our prime axes. Next. And by doing so, as we saw in the first slide Lars showed, Sweden is a very small country. Even if it's fun to develop things ourselves, we are part of a greater community seen from a global perspective. And there is a lot of people out there having great minds, and we want to cherish that and also be able to have advanced in our evolution in healthcare by using that. And that's why we're looking into standards. And that's great, but the challenges is actually there are so many to choose from, and some of the standards actually are hitting in some peripheral parts the same domain. Next. So when it came to pathology, we saw that DICOM were actually one of the major standards out there that we would like to use, because some of that parts of digital pathology could have a lot of use and value from that part. And just to take it from a very basic level, DICOM is actually a two-part standard. The one on the left side is actually how it describes an object definition, and mostly the image within is a JPEG, and then you encapsulate that with metadata that describes how the image is built and also the demographics around that patient. And on the right hand side, and the second part of DICOM, it's also a communication standard with great functionalities that could provide the trust that nothing is lost in translation. Next. The DICOM model is actually this. It's bound out of an information model where you have the focus on the patient level, and then you have the study level, and that comprises of series information, and then you have the image information. And depending on what kind of domain and what kind of problem you want to solve, you use different of these modules, and you can use them all, and you could just use one specific. But the interesting part is that the DICOM information model is that you inherited. So it's a kind of a parent-child model. And that's very vital for us to provide the correct information. Next. just an introduction to digital pathology. Next. So this is the workflow we have today, and when it comes to digital pathology, not as easy as we did in radiology. Most of the action taking part of the workflow today is actually manual. It's an analog part. So to fully understand, it would be great to digitize a lot of the steps as of today, but some parts as of today we cannot digitize. For instance, the specimen is actually an analog part that we later on digitize. So there is issues with the workflow that we cannot solve today, but hopefully we can do that in the future. Good. And what we want to achieve with the digital pathology is go to the process-oriented digital pathology, but it should not be within the department itself, because then you gain not so high value, but we look into a more out of an enterprise perspective. And just to have it in an application, because there is solutions out there that you could buy as an application, but that doesn't take in consideration of how you change the work or the way you do the work today. Next. And by using standards, we could see the possibilities that other ologies has already encountered and hopefully solved. But we could also encounter domain-specific problems that no one has seen before. Next. So one of the things is when it comes to image quality and inconsistency, we have here an image from radiology where they actually encounter problem with the image quality and inconsistency. And the standard for the radiology part actually solve this problem, so the inconsistency is not any problem anymore in radiology, and that is how their information is created. So we take a lot of this work that already being carried out and take it into consideration for digital pathology as well. Next. Here is just another example of the inconsistency, and there is a lot of knowledge already been working on. Next. And will we encounter the same issues? Yeah, in some cases, yes, because how we create the image in the DICOM is not the same way as it's done in other ologies. The resolution is, the performance and resolution is much higher when it comes to pathology and other ologies, and also that demands higher or better performance from the technology, as the images are much bigger than in radiology. But you work in a different way with those images in pathology as you do in radiology. In radiology, we look into more historical exams than we do in pathology. Yeah, we do it in a small sample of it. Next. And digital pathology is what we see the technology for the future, because as we are working with the biological material, it deteriorates when it comes to quality and so on. But when you digitize it and have a digital image of that specimen, it actually almost lasts forever. So it's very consistent when you do it there. And then you have all the other possibilities that the technology gives you. You could have tools for counting cells and stuff like that, that now you're doing it manually and you're very dependent on the human. Next. And in 2007, I think, the DICOM committee saw that there is a need for having a work group, a specific domain that took the pathology domain under their wings, and that is working group 26, and that is one of I co-chair, and we have 2 specific supplements and a lot of CP, the change proposals. The first one is how you define the specimen and the module, how you handle containers, slice, and so on. To have that as a standardized way. So when you are fully digitalized, you could share them in a common and understandable way. And then the second part is the supplement 145, which actually describe how you create the whole image slide. And I will come back to that in a later. Next. And once again, we have one standard and many vendors, but the interpretation of the standard is widely, and that's why we need to be very specific when we write the implementation guides, and that's the area where IHE PALM is now working. And as was mentioned in my introduction, we are now working on the first integration profile that is actually the basic profile for digital pathology workflow. Very simple, but it's complex due to the way we work of today. But in itself, it's not so complex. Next. And this is the more in-depth technology overview, how we create those VSI. In the bottom of the pyramid, you see the baseline. That's actually where we create the highest resolution. And then you have different layers. And by having these layers, you have the possibility of doing the zoom, as you have when you're working with an analog microscope. And then we have the thumbnail image in top of the pyramid. That's actually the low resolution part. So having technology where you could stream this information, even if the file itself is pretty large, we could actually gain performance by having this structure of creating and store the images. Next. And this is how we tweak them into single frame, multi-frame, and multi-frame where you have the Z plans and color planes. So we actually add on, and this is what we are now doing in our Connectathons, where we participate in various pathology conferences and actually show that this is not just a desk or a theoretical model. It actually works in real life as well. Next. Then we have issues that we haven't considered before, because if you have a normal glass and investigate that in your microscope, you know the coordinates and the origin of the slide, but when you scan it, you need to know where is the slide coordinates origin, and then the X and Z and Y description. Otherwise, it could be hard to interpret, and this is also things that will be covered in the standard. Next. And then you have the complexity. When you scan a glass, which exam does that glass belongs to? It's very seldom you just have one glass per use case. You have one too many, and we need to figure that out so that the pathologist could have a good overview working digital and doing the diagnostic work. Next. And just to do the conclusion dialogue, could do it next. So we can be talking about technology forever, but what we have seen is the problem and risk quantification is actually that we need to see what kind of standards, and Lars mentioned FHIR. FHIR is one part of the standard that provides functionality in some areas, but we need to actually decide. So when we communicate and be part of a bigger enterprise, people that connect to us know what kind of standards we're doing. We need to focus on the data mining, and how that is possible is just to be very rigid when you create data. So it's created out of the same frameworks. We need to have interoperable systems, and the systems need to be considered as tools for the clinical staff. Nothing more than a scalpel. A computer is just as simple as a scalpel, but its content is the complex part. And then when we open up for the possibilities of actually making the earth is flat, we need to look into the ethics and security. But here in Sweden, we have a problem that we actually, we always start with the security and do the problem analysis, and then we drown. I think that we should add one focus there is see ethics, possibilities, and security. And from that, predicting your medical future, because we have a lot of great technologies out there. If we could just have a harmonized information and share that, we could actually create better value for our patients. Next. And to summarize that the technical solution is only a peripheral challenge. What we have seen, and that's our main goal, is to create a heterogeneous information model. And based on that information model, where when everybody knows what we are talking about and how we define it and how we code things, then we could have a workflow, and that opens up new ways of organizing people to work. And we have seen that in our radiology domain, where we actually have been ahead for 8 years now or something from pathology, where we do a lot of diagnostic work in Sydney, Australia, Barcelona, Spain, and Hawaii, United States. So we are not slaves under the clock anymore. So we have a lot of office hours. We just move around the globe. Next. And for us, from our perspective, healthcare is all about the data, the quality of the data, and also the meeting with the patient. And for optimal care, we need to have that data shared. And to create that trust, we need to have that based on the information model we're talking about. And the last there, accurate decision making improves patient care, reduces cost, and ultimately saves lives. And yeah, we see that we in some cases have been working with inaccurate data, and that creates consequences both for the staff and also for the patient himself. Next. And this is my last remark. It's not always what you see that will create the possible value, but it's actually what you're working with. And when discussing with clinical staff members, they don't actually always see the value of the information and informatics. But when you have the dialogue with them, they understand that that's actually our key resources, together with the patient, that creates the context of that data. Next. And like Sir Winston Churchill said, this is not the end, it's not even the beginning of the end, it's the only end of the beginning. So with digital pathology and other ologies, we see a possibility if we can negotiate a common information model, that we just open up a lot of possibilities, and all of those possibilities will just give us better care and a great possibility to actually come to the conclusion of providing personalized medicine for the patient. I'm done. Thank you.
So thank you, Lars, and thank you, Mikael, for a wonderful presentation. And I really like some of your slides with the example of the carrot and this quote from Winston Churchill. So if I understand it right, then if this is before the end of the beginning, I hope that we have soon some India and Sweden collaboration where you could harmonize the standards and the flow of data. And unfortunately, we were supposed to have a very good pathologist joining us today, Dr. Ravi Gaur, but he's not well and he could not join us today. But I'm sure that you would like to know very quickly the Indian point of view. So
Yes.
I would invite Dr. VK Singh, who is a medical expert, and he could give you maybe in next 2-3 minutes a very quick overview where India is.
Thank you.
Welcome.
Thank you, Sachin. Hi, Janos. I know you, not other two, but I know you well. Hi, how are you? Now, let me mention to you the Indian perspective. I'm also doctor by profession, but more onto the management and policy, etc. Well, we are yet to become a digital India in terms of health, which we are lagging behind far, far. We don't have our digitalization of the clinical records. This is still quite a few years away. Maybe it'll take 5 to 7, 8 years. We have drafted our bill for privacy as you have in Europe, which is yet to pass from the parliament. The interoperability is the problem. And every chain, like a private hospital chain, they are having their own digital system, but not to that extent. Indian hospitals, the government one, they're still standardizing. They have different splintering of the system. They're still standardizing it. We are following ICD 9. 10 is also been told to fly. But as far as SNOMED CT is concerned, which is the one the government of India just acquired a license for that. And in the government hospital, they've told that try it and find out what is the problem. And the private hospital, I am really not very sure to update you how far they have gone for the SNOMED CT clinical terminology. Now, in that extent, IBM tried using the cancer patients with the Manipal hospital because the data was not really reliable and so many other issues. I was talking to IBM people, and that has project is also in midway, or I can say in the limbo. What is being done at the My India national level, we are far behind what you are talking about, because I do understand whatever you told me, though I am not a IT person, neither am but as a doctor or a policy maker, I do understand. Now, our the organization at the government level, they are trying to deploy the CDAC as the organization. The hospital management is for a system where we will deploy and operationalize on a nationwide scale, especially in government medical facility in India. I'm talking about the SNOMED, and we'll identify, present the key challenges faced during effort to integrate SNOMED CT with our large-scale legacy system, followed by the strategy adopted for resolving them in the government system and subsequently take it to the private system. So this is a nutshell that you would understand that compared to what you are talking, we still have to catch up. Though our people are trained, but I think it will take 5 to 7 years to catch up, and that the government is very much trying, and probably health is the last priority, but this present government trying to push it. The budget is coming tomorrow. There's a rumor that quite a bit of thing will be given as a part of the GDP to the health. Today is only 1.5%. So this is the nutshell which I wanted to tell, that what is the gap. So probably we have a lot to learn from you. We leapfrog your knowledge, and you will know how far we can do it from this legacy to your legacy. Thank you.
Thank you.
Thank you, Dr. That was useful, and my takeaway, Lars, from your presentation was, because I was wondering what is the cost analysis, and I saw in one of your slide you mentioned early diagnosis means less cost. I don't know whether it was in your slide or in Mikhail's, but I saw it somewhere there. So I have, one question which maybe Janos, you, Mikhail, of you can answer. So maybe you got some idea from Dr. Singh about India. Janos has already, been working in India. He has a clinic here, so probably he understands India a bit more. What do you see are the synergies with your work and with the kind of establishments we have here in India? Are there any early ideas?
Thank you. What I think is maybe in this phase it would be good to find a partner in India which can be interested in implementing the early steps of digitalized pathology in some institutions. That's why it's pity that we don't have the representative of OnQuest. It might be good potential partner, but I think during next connections, maybe this can be one thing what you, Sachin, could be take into account as you are planning a delegation to Vitalis from Indian partners and Indian companies and hospitals. Maybe there is somebody who really wants to take it in more detail than there is during Vitalis, to have more in detail, more in-depth discussions on this. This would be my immediate sort of idea.
Thank you.
I think it's an excellent idea, actually.
Yeah. So I just want to introduce. So Mikhail and Lars, before you respond, I just want to also mention that we have one person attending this webinar, Mr. Mukul Bagga, and he has been heading one of the large diagnostic chain players in India. Maybe Mr. Mukul Bagga can correct me. I think it was Quest Diagnostics, and I think now he's involved with some kind of an advisor role in multiple startups. So he's mentioning in comments that DigiBridge Healthcare is working on a telepathology model and would be interested. So what I can say through this webinar already, I think you already have some interested partners, and since we know Mr. Bagga, we also highly recommend him. So maybe we will pass on your contact details to him and hope that more collaboration happens. So Lars and Mikhail, do you want to further comment on this?
It's
I
Lars.
think sorry.
I think it's a very good idea, and I really promote the way that we start collaboration. I will see that I can arrange for some separate meetings if you have a delegation coming to Vitalis also. So you will meet the health and welfare part of Sweden also, so we can have some big plans on how to do it. You know that we have an agreement between Sweden and India on how to cooperate for health. I'm not so into it yet, but I'm trying to understand that we are looking at more opportunities to work closer to each other. So that could also be something I will dig up so we can discuss during Vitalis. And obviously, I think, Janos, you will be in Vitalis also this year.
Yes, we will have on May 22nd, we will have also Scanbelt Executive Committee in the morning. And we have had a discussion yesterday with Sachin that we should actually find the good ways how the Indian delegations could be actually take part of our executive committee. And also afternoon there is a planned a business seminar over India Nordic business seminar, which also we could actually take this topic as one of the possible topics among the others.
Very good, very good.
So before you comment, Mikael, I just want to add what Lars said about India and Sweden. So they are completing 10 years of the partnership.
Yes.
And on 23rd of February, your health minister would be here in India. So that's a milestone in a way. So hopefully that this collaboration will continue. I'm not sure whether you are aware of this visit, but maybe at some point our health minister might also visit Sweden later this year.
You know,
But
the
we will also
problem we had in Sweden with our ministers, it was just for 1 or 2 weeks ago that it was cleared out.
exactly. So Mikael, over to you before we wrap up the webinar. I can see that there are questions coming, but we are running out of time. So for your comment, please.
Yeah, yes, shortly about telepathology possibilities, as India is a very large country. It's not just about technology, and we can discuss that in Vitalis with the delegation. What we see is actually very nice to go into the medical school and do some training there to prepare the students when they actually start working in the hospitals, be prepared for these new tools. And then we have seen that you have a jump start. You don't need to start training them when they are employed, but before that. So, yeah.
Mm.
Okay. So there is a question, maybe, the person asking Mr. Sudipta Datta, he's saying that what are the personnel and equipment needed if they were to implement this digital pathology at a hub and spoke level. So since we are running out of time, I just want to read out this question. But maybe Sudipta, if you don't mind, we can share the email of Lars and Mikael. Hope that is okay with Lars and Mikael. If there are any further questions, people can write to you. Is that okay?
Absolutely.
Okay. Okay. Okay, Sudipta, then we will share the email with you, and maybe you can write to Lars and Mikael. So I would like to thank you once again, Janos, Lars, and Mikael, for taking out time and doing your part of building the collaboration between India and Europe. And also, I would like to thank Dr. Singh to bring the Indian perspective. And we are also committed as Innovation Curious to support this cause. And we are planning our next webinar in this series in February, where we will have Finnish Professor Paul Lilrank with Indian Dr. Vijay Agarwal, who is heading a consortium of accredited hospitals of India, talking about similar ideas. So if you are interested, those who are attending today and also our Swedish friends, please join in, and maybe this will also give you more ideas about Indian side. Thank you very much. Have a good day.
Thank you from Sweden also, and we are interested. Thank you.
Thank you.
Thank you.
Thank you. Thank you, Janos.